um, trying to we are trying to involve at least 4 or 5 remote care physicians, and what we are trying to do, if it is successful, then we can bring it to a broader audience in terms of telling them that how to handle common presentations. So we have done this before, but I say this all the time, that when there is a question about somebody presenting in the point of care, we need to ask 3 questions: that why you are here, and have you been here, and whether you have any cardiac conditions or any comorbidities. And why it is important, because if you look at the whole cardiovascular system diseases, after 8 or 9 symptoms, we cannot actually find any anymore. Like, one of the most important thing is chest pain, shortness of breath, palpitation, dizziness, transient loss of consciousness with full recovery, like syncope, or patient is unconscious and not responding. And we need to figure out whether cardiac issues are the cause. Patients can present with cough, nausea, vomiting, sweating, and then subacute presentation can be vague, like fatigue, unwell, leg swelling, etc. And comorbidities and what the patients are taking in terms of medications are very important. So any remote care physicians, when they are contacting us, and that's we are trying to do from the point of care centers, they are contacting the experts. Some of the eminent experts are on this panel today. They would like to know, in addition to the clinical presentation, how is the patient doing now in terms of heart rate, blood pressure, temperature, pulse ox, and the EKG, and a very basic exam finding. Sometimes they may ask the point of care doctor. So let me ask you this question, and this is going to be a little personal. This is a 55-year-old male from north of Bangladesh, somehow related to me, and this patient presented with fatigue, occasional shortness of breath, and chest tightness. And this is his EKG.
Dr. Hassan, we don't see your presentation. Can you
You don't
share
see
again?
my presentation?
Yeah.
No, I can see.
No,
You can
not
see?
visible. Only we can see you.
Oh, okay. Let me see. Share.
Yeah, now we can see your screen.
Yeah. And now if you open the PowerPoint, we can probably see.
Can you see
Yeah,
that
yeah.
now?
Yes.
Yes.
Yes,
Now
can
you can
be.
see?
Yes.
That was a scientific move on my part of not. So this is the thing we have done before with other experts with a specific symptom. But today we are going to give a broad spectrum of, if you think about this, I mentioned 3 questions we need to ask every time somebody is coming to your center. Ask why he is there. What is the primary symptom the patient is coming with? And then ask, and if you look at whole cardiology, I could not find more than this: chest pain, shortness of breath, palpitation, dizziness, transient loss of consciousness, full recovery, syncope, unconscious and not responding, cough, nausea, vomiting, sweating, and subacute presentation, fatigue, unwell. Right? If you think about anything more, tell me now, because this is pretty much comprehensive list of how patient presents. Patient does not present
Yeah.
with heart attack.
Yeah, some patients complains of some gas,
Gas.
abdominal gas and
Okay.
fullness like this.
So, Mahbub, excellent point. This gas will come under chest pain.
Okay.
And then we need to tease out whether this is reflux or this is. But in general, we have trainee doctors in this meeting. If it is 70-year-old with symptom like gas, there is a red flag. If somebody had a stent, bypass surgery, and calling gas that woke him up at 5 in the morning, that is a red flag.
Yes.
And somebody 22-year-old and coming with gas, it may not be green, but it is not red. You can evaluate further. And I'm saying this, in Bangladesh, there is an issue, right? Because even the
Yes.
young patients can present with MI early on. So
Yeah.
this patient, 55-year-old, it is from north of Bangladesh, diabetes, hypertension, hyperlipidemia, and patient has fatigue, shortness of breath, and some chest pain on exertion. He works in a local bank and does not want to go to Dhaka. And he's a distant relative of mine. And they asked me what to do. Any comment by looking at this EKG, anyone?
Can you make the ECG bigger?
Yeah.
Hello?
Can make the ECG bigger?
Okay.
Can make the ECG bigger?
Enlarge.
Let me see. Yeah.
Yeah. Having these risk factors, male 55, hypertensive, diabetic, dyslipidemic, and with this symptom and with this ECG change, this is definitely an acute coronary syndrome, whatever.
Yeah. So in a remote area, Baranda.
It's because the patient is diabetic. The patient may not have any chest pain also, but his ECG is suggestive of ischemia, most likely in the LAD territory.
Right. Kind of Wallens type picture, right?
Correct, correct. But
Yeah,
Wallens is
yeah,
little
yeah.
bit different, but looks like it's a Wallens type because
Semi-Wallen, yeah.
Wallens, the upper one is more bigger than the lower one,
Yeah.
the
Yeah.
biphasic.
But
So
Yeah.
it looks like Wallens type 1.
As Mahbub said, you smell like Wallens, right?
Yes. Yes.
So my question is, what can we say? Anybody from outside Dhaka or Ashulia or Bagherat, any question? What will you do? I mean, we encourage you that you upload this EKG for us, for the experts. But in the meantime, you can do physical exam, make sure there is no heart murmur, patient is not in heart failure. That will be helpful to us. You can tell us about the heart rate and blood pressure, and then you can do a point of care troponin also, right?
One thing I
Yes.
want to tell, this patient presented as a chronic stable condition. It's not an acute one, correct?
Well, this is the part I wanted to tease out, right? It can be acute on a chronic problem, or it can be
Yes.
subacute
Because
on a chronic problem.
It's
We don't know.
Looks like a chronic case, occasional fatigue, SOB, and tightness
Yes.
on the chest on exertion.
Yeah, that is exactly right. So if this patient comes to any major hospital in Dhaka, what will you do?
So we will stratify the risks. First thing that his ECG looks like it's the ischemic because the patient is diabetic and symptoms are also suggestive of ischemic heart disease because all the diabetic patient does not come with chest pain because his features like SOB, these are all angina equivalent. So this patient, what we do, we'll do a definitely top eye test, but one echo is very important. What about his LV function? When on this assessment and all the features on the background of this diabetes and other things, he's a 55. I don't know whether he's a smoker or not. So
He's not a smoker. And
he's a smoker.
No, he's not.
বরেন স্যারকে দেখা যায় না
Yeah.
Oh, দেখা যায় না শোনা গেলেই হবে
শোনা
আচ্ছা,
গেলেই
বলেন।
হবে।
হ্যাঁ বলেন হ্যাঁ
So I think patient should go for a top eye test and the patient should go for a echocardiogram for evaluation. Ultimately, the patient will require a coronary angiogram to stratify his coronary status.
Okay.
Yes, can I add something?
Yeah.
With this ECG, I will admit the patient to coronary care unit, do the troponin T and bedside echocardiogram. If troponin T is raised, we'll directly send the patient to cath.
Okay. And the troponin T, say, for example, is pending. And Dr. Jeff Lee or Nilish, in US, what you are going to do? Are you going to take to the cath lab, or you want to admit, or you want to do what? Do an echo and wall motion?
Yeah, I think that here in the US, we definitely do a bedside echo and then trend the troponin levels, and depending on the patient's clinical status, and if the patient's having active chest pain, then that will kind of allow us to risk stratify and see if we need to cath this patient earlier than later. I think that I agree this patient definitely warrants a coronary angiogram based on the risk factors and the EKG changes.
Because the issue is that if it is
Hafiz,
CAD, it is looks like a proximal LAD.
Yes, that's
And that
correct.
has significant mortality implication. So it is not
Right.
something ignorable. However,
Right.
all my advice ignored, and the patient is still in the north of Bangladesh. And because you know why? Because he thinks that it will affect his job. He's trying to get leave from his job and trying to collect money so that when he comes to Dhaka, he can pay the bill. That is a huge problem, right? So when I heard that, I told him that this can basically jeopardize his life. So he is on
Yes.
his way to Dhaka now. With that in said, we talked about biphasic T. This is my cousin from my hometown with diabetes, hypertension. You guys know, those are from US. It is very prevalent, diabetes in Bangladesh. And then he had
Yes.
1 or 2 episodes of chest pain, shortness of breath, and then he had an EKG locally, and he sent me this EKG. How bad it is? Is it gas or is it some heart problem?
Gas
patient
is
has
visible.
anterior MI,
Yeah, gas is
fully evolved
visible. Right.
anterior MI.
Yes.
And by the way, for the previous patient, even in the US, we would, if the story is good and troponin does not matter how high or how low,
Yes.
is it even not troponin negative? If the story is good, that patient needs to go to the cath lab because of proximity. And
Yes.
and in Bangladesh also it is important because if you do other tests, it has incremental cost. Cath will be for $225 diagnostic.
Yes.
So I think it is
Not
worth.
and
In
not only
fact,
that, here what happens here, the patient comes to a chamber, outpatient department, and the doctors prescribe for troponin and echocardiography evaluation, and then patient goes to echocardio room in another hospital and do the echocardiogram and pending the report for 1 day or 12 hours or so, and troponin from another hospital 12 hours or so, and then when he comes back already infected and then gone.
And Mabu, very important point, because we need to tell the patient that how significant these findings are, and how it can implicate prognosis in terms of mortality. And we have a case about that. So
Hafiz,
this is a real case. My first cousin, and then
this one I
presented,
saw.
this presented with this EKG, and any doctor from outside Dhaka city joining us will take this, because, and also, I don't know, Borenda and Mahbub, we need to talk to you guys what EKG system you are using. The EKG system now can give more diagnosis on the top. And we are now having artificial intelligence, and you know that occluded MI, the picking up rate by the artificial intelligence actually is better than even the cardiologist. So this is something interesting.
We usually do not bother. We usually do not bother what is written
No,
in the
Borenda,
upside.
it is not for you.
We always see the issue.
Yeah, it is not for you. I'm saying in the remote area, that can be a
remote area.
guidance. And that may be helpful to understand the seriousness of the problem and upload this in our app so that we as a group can help them and ask them that how is the patient doing. The same EKG with this same patient, 48-year-old, maybe hypotensive in shock, or maybe
Yes.
stable, but still having chest pain or calling it gas. And
Yes.
this is important because I show you this. I'm not showing the name of the point of care center. I'm not showing you the doctor's name. It's a junior doctor. He did his
Yes.
best,
Yes.
and I appreciate.
Yes,
He
The
said,
loading
recently
dose.
kindly consult with cardiologist.
concern cardiologist.
I mean, that is absolutely not acceptable, right? It is not his fault. I'm not blaming him. There is no system of care
Care,
built
right.
in our country.
Yeah.
He
is
should
sad.
send
He
the
should-
patient to hospital.
Yeah,
Look
he
at
should
this.
go to a cardiac
Look-
center
Look
directly.
at this.
Not
Not
a
cardiac center, any cardiac center.
yeah.
That doctor, he or she actually understood what it is. I think
Yeah.
understood because writing clopidase, atova,
Yes.
and this is pantoprazole. Those of
Yeah.
you from like Jeff and Nilish, I don't know,
Yeah.
Nilish is on the line. They gave these antiplatelets right away, but
Yeah.
there is no system of care. There is no
Exactly.
how this patient is supposed to know that this is a significant problem that can jeopardize his life. So what happened? The patient's wife called my sister called me, but the patient was smart, got a picture of the EKG, sent the EKG to me, and I called Mahbub. Mahbub was in sleep. And then I called my wife. My wife called Mahbub's wife. Then Mahbub's wife's from Maryland called Mahbub. And then he woke up and in fact, he saw the EKG already. So he did
Yeah.
not bother. He already was in the car and told me that he's on the way. And this guy had a cardiac arrest, BP arrest, shocked 3 times. But my question is, who should get the credit? Should the patient get the credit? Wife should get the credit? My sister get the credit? Or I should get the credit? Or my wife should get the credit? Or my Mahbub's wife should get the credit? Mahbub should get the credit? Or Katlaf should get the credit? So this is a
I think
choreography.
yeah, I
STEMI.
think that yeah.
Yeah, Mahbub.
Yeah. I think the initial the patient should get the credit
No,
because
Mahbub,
he
let me tell you something. I
Okay.
wanted to throw this up because this is a coordinated thing. If you win, the team wins. If any member failed in this chain,
team
this
will
patient
fail.
would not be alive, right? So for STEMI care or high risk PCI or acute cardiac care, we need the team. And that's the reason I'm trying to build this theme of the team. It doesn't matter who is and somebody has to be the captain of the team, of course, but everybody has a big role to make it a success. And with that note, I want to know anyone from the remote areas or Ashuli or Bagarat has any question so far. And look at this. This is Bangladesh, and the door-to balloon and the outcome was absolutely fantastic because there was coordination of care and somehow it worked and patient is alive. And this is only last week. Patient is already home. So, and a commendable work by Mahbub. And this is the EKG subsequently. Jeff and Nilish, you can see the reperfusion is established and it's a very good thing, right? So, Rafiq Bhai, are you still there? Do you have any comment?
Sure. I mean,
I want to know from you about this beefy business because Rafiq Bhai is the father figure of electrophysiology in Bangladesh. Actually, he has started the program in Bangladesh, and we both are very passionate, and he has injected more passion into me because we need these defibrillators available. Because Rafiq Bhai, without the defibrillator, he will be dead, right?
sure. No, I think I mean, look at it. We can look at the negative side, but think about it that 15 years ago, this patient will be dead. No question about it. We need to go along more, but there is still chain of communication. I mean, it happened to one of my friend. He went to a hospital, then I had him moved to another hospital in Dhaka, and within 90 minutes got an angioplasty. But not everybody has that communication. But one of the things that we need to talk to primary care doctor, the doctor who saw it first time, instead of saying that, look, go to a cardiologist, he should have picked up the phone. And all the cardiologists are available now in Bangladesh to be reached. That would have saved time. So that's something, it's a work in progress. And I think we should continue encouraging that communication.
So Barinda or Mahbub, any comment?
Now, actually, what you have told, that is, it is a teamwork. It is a teamwork, an integrated, coordinated teamwork. Without the team, nobody can do the things smoothly. And we are lucky that we have a 24-hour 7 team in cath lab team in our hospital, and we have one site cardiac cath team always on site, except senior consultant cardiologist. Other team members are there, stay in the hospital 24 hours. So it's an advantage for us. Team already there. When we go the hospital, already patient is on the table most of the cases. So it is lucky for us and for the patients also.
I think what Mahbub you just said, Nilish, you have any comment on this? Because you worked in Middle East and also you have some exposure in India. This team already in the cath lab overnight is a plus, because only person then the variable is the interventional cardiologist driving to the hospital, right?
Yes.
Yeah, I think one thing is the overall anxiety of the hospital system you're working in also reduces because they know that they have a backup of the team in-house. So then there is no delay from the emergency department or wherever the patient is at. So the healthcare system itself and the doctors in the healthcare system feel a little bit more empowered to tackle on these situations because they've seen more and more of this, and they're hopeful of getting a positive outcome. So that is very important to have a team in-house at all times, 100%.
So now I want to ask a question like chest pain, and they say that the EKG is unremarkable, and the EKG report computer generated says nothing major abnormal, and patient is 50-year-old, chest pain, diabetes. What will make you comfortable to send the patient home? Any comment?
No.
Hafiz, I want to say one thing.
Yeah.
Even the patient when comes with chest pain, many studies have shown that 15% of the patient who have STEMI, their initial ECG may be normal. So it does not mean that single ECG, that's where the patient is, nothing is having. So we'll have to redo the ECG and do the troponin I, and you must see that the last ESC, the 2200, 1 hour. So how to dispose the patient, roll in, roll out on observation. So we'll have to repeat the ECG, and then we'll have to do the troponin I test, but preferably in other countries, the high sensitivity troponin, but in our institution, we do the troponin I test. So until and unless I am confirmed that it is not an SES, we cannot tell the patient go home.
Yeah. So যারা শুনছেন যে আমাদের পয়েন্ট অফ কেয়ার সেন্টারগুলোতে আমরা যদি ইসিজিটা করি, ইসিজি যদি আমাদেরকে দেখান, আমরা আপনাদেরকে হেল্প করতে পারবো। প্লাস আপনারা রোগীকে বলেন যে একটু বসেন, বাট আমরা 2 ঘন্টা পরে আরেকটা টেস্ট করি। If there is a 20% change, then it is significant. And then you can, but if there is no change, then we can make a shared decision making. রোগীকে বলা যে আপনারা এখন ভালো বোধ করছেন, বাসায় যান, কিন্তু বুকে ব্যথা আবার উঠলে কিন্তু সাথে সাথে হাসপাতালে যেতে হবে। তা না হলে আপনারা আগামী সপ্তাহে একজন ডাক্তারকে ভালো করে দেখান। এটা হচ্ছে
Even troponin I should be repeated.
Yes, absolutely. So this is the called interval troponin. with repeat EKG can be of help. Are
Yes.
you guys okay with that strategy?
Yes.
Yeah.
I think we should give more emphasis to the risk factors and symptoms of this
Yes.
patient, middle-aged and high risk factor, diabetic,
Right.
and symptoms. So I think ECG may be normal. Sometimes short territory may not give any changes in ECG, and
Right.
major diagonal, major OM may not give any change in ECG. But the risk factors profile is very suggestive of this coronary
And in the
syndrome.
point of care center, if you confine the patient for those who are like, you are not sure, ECG is okay, blood pressure good, heart rate good, confine them, তাদেরকে 2-3 ঘন্টা বসায় রাখেন, আরেকটা
Absolutely.
টেস্ট করেন, and দরকার হলে আরেকটা ECG করেন, and then you can tell them, if the pain is completely gone, then the patient will be also satisfied that I can go home. If the troponin
This is
no
almost
change, yeah, but that is called the shared decision making. এখানে কোনো লায়াবিলিটির ব্যাপার নাই, কিন্তু পেশেন্ট যদি still having pain, you are not sure, then you need to give them the advice that we are a point of care center, a small place. If you're still having pain, not sure, please go to a bigger hospital. But I can tell you, across board, with our experience, আমাদের হাসপাতালের emergency room, vast majority of the patients you will be able to go send home. And in Bangladesh, the cost is mainly by going to the hospital, and hospital
Yes.
cost is huge. So we have a very difficult and challenging job. On one hand, we don't want to miss the nasty disease, life-threatening disease. On the other hand, we don't want to overdo things so that it will be taxed on the patient for unnecessary testing and hospitalization because of fear. How to alleviate fear? We need to have knowledge and some tools and some collaboration. Use the experts in the back end. আমরা আপনার সেন্টারে নাই, but we can help you by looking at the EKG, another extra pair of eyes, looking at the same EKG, maybe with more expertise and knowledge and experience. And also, you have the benefit of confining the patient for 2 to 3 hours and then repeat test. So this is the whole story of the chest pain. Big 5 chest pain causes that can jeopardize life. One is acute myocardial infarction, STEMI and high risk non-STEMI. And remember, if the patient is hypotensive, shock, that patient's mortality is, regardless what it is very high. Another thing can cause this problem is pulmonary embolism. We are telling that Dr. Jeff Lay, who is working now in San Diego Scripps, he just did a pulmonary embolism thrombus extraction in acute PE to save life in massive pulmonary embolism. That can give you chest pain, severe hypoxia, and very important, severe hypoxia. And also point of care ultrasound, you can pick up that the RV is struggling, right ventricle is struggling. And that's why we are going to train you on the point of care ultrasound as well. And when we talk about the vitals, heart rate, blood pressure, oxygenation, EKG, and temperature, these are very important. So any editorial comment by any faculty on this? Oh, before that, I want to mention acute myocardial infarction, pulmonary embolism, aortic dissection. My good friend Shakil Farid is not here. He sees more dissection than any of us sees because he works in a tertiary care place in UK. They see all kinds of issues with aortic diseases, but you may see dissection. I think probably it is underdiagnosed because we probably miss it and they die on the way. So that also can be helped if you involve us, because
in Hafiz,
yeah,
in aortic dissection, sometimes ECG may be non-diagnostic, very difficult
That
to
is true,
diagnose.
but also
the-
it can be inferior STEMI, and you may have a right coronary dissection. Usually, you
but
don't
only
need
thing
to.
is that
Yeah.
we can diagnose, usually in our institution also we diagnose several cases of aortic dissection only bedside only. So
Yes.
development
And-
of a new aortic regurgitation murmur and
Yes.
the asymmetrical pulse is very important. Asymmetrical pulse.
Yeah.
And
But
along with that
asymmetrical
one,
pulse
if
also,
you do an echo,
also maybe not so helpful, but point of care ultrasound with aortic regurgitation
ultrasound
and
is
pericardial effusion will be
so it-
huge.
correct.
Yeah.
And the new onset of aortic regurgitation and sometimes
Right.
flap also can be seen.
Correct. So these are the big five: acute myocardial infarction, pulmonary embolism, aortic dissection, pneumothorax, tension pneumothorax. That is very easy to diagnose. You use your stethoscope and then you hear this severe hypoxia and no breath sound on the other. It is very easy. And also the history of emphysema and that also will help. And then
But
esophageal rupture.
in the scenario of non-diagnostic ECG, diffuse esophageal spasm also can give rise to severe central chest pain.
Correct. And in those cases, just repeat EKG, repeat troponin, check the vitals. Remember, tension pneumothorax, esophageal rupture, your vitals, blood pressure, heart rate will not remain normal. Yeah. So let me summarize this part of chest pain. So we talked about 5 major causes of chest pain. We talked about that, how to make sure that this is cardiac or not cardiac. There may be other cardiac causes of chest pain, acute pericarditis.
Yes.
But my question is, keep it simple and involve us with your EKG and the patient info. In the back end, will help you. So with that, let me go to a second case where this is a male patient with shortness of breath, and in Upojila, doctor did a chest x-ray, and the patient came in with this chest x-ray with shortness of breath in the point of care center. And this is
This X-ray is AP view or PA view?
You
It's
figure
PA
it
view.
out.
It's PA view.
It's PA view?
Yeah.
Yeah, Pandic gas is there.
But Boranda, does it matter? Because there is cardiomegaly.
Because
Yeah.
yes, it matters. Because in AP view, the heart appears to be enlarged.
Yes.
Yeah, but Pandic
Okay.
gas is here. Pandic
Yeah,
gas
I
is
saw
seen.
that. I see that.
Yes.
Yeah.
What
So
about
PA view mostly.
then you have this EKG,
Yeah.
the sinus rhythm left bundle.
Lead
Yes.
bundle is
Can
yeah.
make it little bit bigger?
Yeah, LBB. Yeah, lead bundle.
Let me see whether I can make it bigger. So left bundle, yeah.
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 So
Left.
and then look at the serum creatinine,
Creatinine little high.
little high, and then we have point of care. Within 15-20 minutes, you can get this this whole thing uploaded, and then BNP came high. So what to do?
So he underwent by echocardiogram or not?
The point of care ultrasound,
Point of care. Basic, yeah. Upojala like
dilated
this.
LV, global
Yeah.
LV dysfunction.
Yeah.
This
So
all the things that patient may be a case of cardiomyopathy, dilated cardiomyopathy.
So will you send to Dhaka for cath? 62-year-old with
Not
some
for CAT. First, the patient must go for a echo Doppler study to see the LV function and other things. Then the patient will go ultimately for CAT. But before that, we'll have to assess the patient. And in this patient, the echocardiogram is mandatory.
Okay. So
Yeah,
here is the
and-
story. So the daughter wants to take the dad to Dhaka city for more care. Dad thinks that it will cost money to the daughter. So dad doesn't want to go to Dhaka city. What will you do?
We have to evaluate locally in a level 3 hospital, Jela level, or in a hospital where the basic cardiographic evaluation tools are available, like echo and not cardiac cath, echo. The echo and pro-BNP is enough to diagnose whether it is LV dysfunction, and surprisingly, the pulmonary fields are clearer. It's not like that left
So
ventricular failures.
this is what I am discussing with Dr. Narula, that
Yeah.
these guidelines are for centers with all the resources. We should not call guidelines and then perceive as this is like written in Bible. We need to cater this patient, because
Yeah.
I thought that there is no point in doing a cath. Creatinine high patient will not be able to, and this is global. So maybe some non-ischemic cardiomyopathy and may get better. So we give GDMT, we give diuretics, actually pre-renal, and with the diuretics decongestion, kidney got better, and the patient got LVEF better in subsequent 4 months' time. My question to you, after
I
4
believe-
months, EF got like 40%, and then question comes in, do you want to evaluate for ischemia?
Yes, we
If
should.
creatinine, yeah, he
Yeah.
should
Creatinine
evaluate for
1.2,
ischemia.
1.3 now.
Yeah,
Yeah.
we should evaluate for ischemia, definitely.
In fact, the earlier creatinine level is a high creatinine level. That was also due to his heart condition.
Correct.
Yeah.
Cardiorenal.
Correct.
Cardiorenal.
Yes. So my question is, ideally or practically, I did not think there is any further need for coronary evaluation. Patient is doing better. What is my problem? If he's doing good, I'm doing good. It's like, your stock performance. The company says that if you are doing good, we are doing good. so
Now,
I did
only
not do.
thing,
So
I
I just
Rafik bhai is there, huh? But if this patient goes for CRTD sometime, so the coronary assessment is also required. In our institution,
Okay,
most of the
so
CRTD patients, they
I
undergo
don't
the
know.
coronary.
Rafik bhai is still there. With
Now,
the GDA,
Hafiz bhai is telling the patient is
Rafik bhai is
asymptomatic.
there. Rafik bhai is there.
Yeah.
no, but
Patient becomes asymptomatic with guideline-directed medical therapy.
and
So
the
why
EF
should
got
we?
better.
Yeah, we have got better. Why should we go for further? That is the question.
Yes.
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 If the patient remains better, symptom free on GDMT, then the CRTD is usually not indicated also.
Exactly. So Rafik bhai, so it was good that we did not jump, right?
Yeah, no, I mean, EF improves, so that goes out of the question. Second, I have when I started teaching ICD, I actually did not want to teach ICD implant in Bangladesh because it's an expensive modality of treatment. And even in the United States, if you look at non-ischemic cardiomyopathy that we are putting ICD, nobody will do this study. If you look back, find out how many patients are getting appropriate shock for non-ischemic cardiomyopathy. That's one question that needs to be answered, but this is a rich country. Until we go bankrupt, we will never answer that question. And this patient ICD question doesn't arise at all because EF has improved. Cardiac cath is very cheap in Bangladesh. I think at some point, even in Bangladesh, low middle income can get a cardiac cath. A diagnostic cardiac cath will be a good thing to do on this patient.
Okay.
And once you know that, then you know that that's it, it's done. We don't have to worry about it. So I will go for a cardiac cath whenever it is doable. One of the things I have noticed in Bangladesh that there is bed crisis, everything, but patients get admitted to hospital just for cath 2-3 days. And that's something that you all need to look at, that, hey, can we make this a day procedure so that patients come in, get the cath done, they go home same day. That will be something to look into.
So that brings
I
us
think,
to
Hafiz
this question,
bhai.
Rafik bhai.
Hafiz,
So, yeah.
I want to add one line only. in our
Yeah.
clinical practice in Bangladesh, in our hospital also, if we get such patients, we recommend definitely GDMT, but we usually, after doing an echo, we do a check angiogram, what is happening inside the coronaries to know the coronary
That's why I'm
status.
asking this question.
Yeah, can I put some one sentence?
Yes.
I think before going to cath, we can assess the viability of the ischemia, that is MPI.
Okay.
Myocardial
So,
perfusion imaging, we can have some inputs
okay.
about the ischemia or
Okay.
non-ischemia.
So
But I go in a reverse way. We usually do the coronary angiogram. Then if there is definitely significant lesions, then we do the viability study, whether that territory is viable or not.
Can I make a comment,
With
Hafiz,
a view
on
to do revascularization.
non-invasive cardiology, Bangladesh is a neglected field.
Yes,
And
true.
that issue is that nobody bothers because everybody wants to do angioplasty. Everybody wants to talk about left main. Everybody wants to talk about bifurcation lesion. So the non-invasive cardiology, development of we need to have a national policy to develop non-invasive cardiology and especially ischemia workup. So sequentially, of course, I will do non-invasive testing first, and then go for cath.
let me modify your statement a little bit. I would not call it non-invasive cardiology. I will call it general cardiology. You cannot be a good interventionalist unless you know the general cardiology first. And my question is, and definitely I agree with that, we need to make our general cardiology, preventive cardiology, and what is best for the patient care in terms of reducing mortality and prognostic implication, emphasize in our curriculum on that, like we do here in the US. My question to the faculty, that we are divided in opinion here, whether we should do cath or not. You know, procedurally speaking, it is not challenging, cost-wise not that bad. But my question is it possible that the patient তার significant left main or proximal LAD ছিল বা আছে, কিন্তু তা সত্ত্বেও গাইডলাইন্স ডিরেক্টেড মেডিকেল থেরাপি দিয়ে ইএফ ইমপ্রুভ করা সম্ভব?
But viability study in this respect is very important.
No, Borenda, we don't need viability. I tell you why. Because if the heart muscle moves, it is viable. One best thing about viability test is that if it moves, hypokinetic still viable. Akinetic is the problem. So
Absolutely.
akinetic means that is it dead or is it dead? In the face of chronic hypoperfusion, if the muscle does not work, we call that hibernation.
Hibernating myocardium.
In that case, we need to test viability. So if it does not move, we cannot write it off. Then we need to check, এটা সুপ্ত হয়ে আছে, এখনো তার ভায়াবিলিটি আছে, অতএব ব্লাড ফ্লো রেস্টোর করলে ওইটা জেগে উঠবে। কিন্তু যদি অলরেডি মুভ করে, then we don't need to do viability because it is moving. It is maybe moving small, অল্প মুভ করতেছে, but it's still moving. So it is the viability is not the question. And in this case, it is fully viable because EF has gotten better globally. But
Even then,
not
MPI can give
yes. So now I'm coming to that.
Yeah.
MPI, cardiac cath in Bangladesh is cheaper than myocardial perfusion imaging. Even in the US, myocardial perfusion imaging, if you do the ischemia testing by PET scan, it could be $1,500 in some places. LexiScan or the pharmacological nuclear can be $1,200. In Bangladesh, I can bet my life that the myocardial perfusion imaging is more expensive than cath, right?
Almost equal.
But in our country, one good thing is that the National Institute of Nuclear Medicine, they are doing the MPI without any cost.
But
it's cheaper.
So we need to be lucky to go there.
না হাফিজ ভাই, The one
Yes.
point is that
Yes,
we
they're
want
doing
to
it.
we want to know the viability as well as the burden of ischemia. আপনি
Okay.
যেটা বললেন যে একটা এলাকা,
So
so
viability
burden of
question is
ischemia,
done. Viability is
Yeah.
there because it is moving. Question is
Yeah.
burden of ischemia, right?
yeah, burden of
So,
ischemia, yes,
so
it
let me
will
tell
guide
you
us.
something. If I do, and Borinda will freak out by listening to this statement, and I know, and I have plans on that. So let me propose this: to reduce cost. Remember, I remind you, he's 62. He has diabetes, borderline diabetes, hypertension. He is not 48. He's 62, and he comes to Dhaka, and with the limited resources, I do a quick calcium score on this patient. Calcium score comes 0. Are you happy that this is non-ischemic cardiomyopathy and continue with the medical therapy and see the LV function
Yes.
gets further better? Or
Yes.
you will reject the calcium score and say, no, I'll still do cath.
The problem
Now
is
we
that
love
the
to.
calcium
Yeah.
CAC may be all the lesions are not calcified, because if the lesions is soft, then the CAC may this calcium score may totally miss it. So if I think that the patient may have ischemic coronary angiogram should be performed, because only doing the calcium scoring, it is not enough.
So
No, cardiomyopathy, this
Jeff Lay
dilated,
is smiling because
dilated heart and improves with medications. So it is unlikely to have soft plaque or like that.
Okay, can I ask you a question?
Yeah.
Mahbub or Boren, what is the cost of cardiac cath in Bangladesh? Diagnostic cath, simple left heart.
Mahbub knows
private
better than
or-
me. It is in our institution, it is around 25,000.
Okay,
In private and yeah.
okay, 25,000 taka.
So Rafiq
So
bhai,
Yes.
$200.
No, okay, no, let's 25,000 taka, which is $200. And I am coming from Mymensingh village, and I have 30,000 taka. You want me to get a calcium score and then get a cath, or you
No,
want me to?
I will do a cath.
So that's the whole point is that. So let's say I am the patient. I am a physician. I have an EF of 39%, and you do an angiogram. My anterior is moving, and I have a lesion of 85%. You want me to get a viability study again and get a stent, or you want me to do a stent directly? What would you do?
Now, if there is no scar tissue and the wall thickness is preserved, so I will do stenting directly.
If the thickness is preserved, if it thickens during systole, so we can go ahead with the PCI.
No, let me put it this way. My septum, my entry wall is 0.7 centimeter. It's moving,
Yes.
but there is dyskinesia. And you have found in angiogram an 85% stenosis.
No.
Will you do a viability?
If the segment is dyskinetic, that means that one is non-viable.
And then we should not do any PCA.
Because in this kinetic segment, what benefit you are getting after putting a stent? Because the segment is not only a kinesia, that is only dyskinetic already. The dyskinetic segment,
But
that is a kinetic.
what you are discussing is all good when you have the disease.
Hypokinetic. I'm talking about wall is hypokinetic.
Yeah, but then Rafiq bhai, the question will come in basically that whether there is a ischemia and burden of ischemia. In the absence of burden of ischemia, then or no ischemia, there is no justification. But
So
in the proximal LAD and left main, we need to really be careful because this has mortality implications. But if it is a third diagonal, I'm not going to be emotional. I will leave it medical therapy.
Sure. So I'm talking about the LAD lesion.
Yes. The prox LAD is a huge deal.
LAD,
yeah, that needs to be evaluated.
Hypokinetic.
Yeah.
And I'm on the table. You have seen 85% stenosis.
Yes. We have to evaluate. We cannot leave it alone.
You're going to put a stent in, right?
No, we need to check. If there is no ischemia, then if you have enough symptoms, I'm convinced I'm good. If not, then I'll do FFR, IFR, or IVA, some other tools to evaluate. for sure.
Basically, I understand if the patient is symptomatic, that means he has got viable myocardium.
Yes, yes.
If chest
Dead muscle
pain is
doesn't
there,
cry. Agree. Dead
Yeah.
muscle doesn't cry. But the
Yes,
question is,
if
in my patient with the calcium score is 0. So what I was trying to make, we had actually world-class authorities in Vegas last month who exactly mentioned this issue, that calcium score 0, and they both are big names, Dr. Budoff and Jim Min. They were both arguing. So the bottom line is, and the message is clear, if it is elderly patient, lot of risk factors, and despite that, calcium score 0, that means after all this accumulated exposure, you still have not joined the atherosclerotic club. That means you are good, but you have all the risk factors, but you are 40, calcium score 0 should not give you this sense of security. Still may be a problem. And depending on the patient's symptoms or patient's LV function, you may go further. And my question is, in resource challenged area, we need to use our common sense and the probability equation. I do not know. My patient still can have multivessel disease. But if I see the LV function gets better and the calcium score at 62 is 0, and I don't see any calcium in the left main and prox LAD on the calcium score, which by the way could be less than 3,000 taka, I think I feel good and continue with the medical therapy until the EF gets better. And then we'll think about whether we can wean off the medications. So আমার মনে হয় যারা শুনছেন তারা বুঝতেছেন যে even the experts at some point they can argue, but there is a consensus here that when you cannot do anything, that doesn't mean that we abandon the patient. We can still try to help. And that help can come with our collective thinking and our knowledge and bringing that to you at the point of care center where you are with the patient. It is not possible for you to know every challenging aspects of cancer or lung problem or heart problem. But if you give us the basic information and use our experts, we can come to your help. It's like this patient is smoker with lot of wheezes, and the family is worried about heart because blood pressure is high, but the chest x-ray is like this and the BNP is normal. Can we assure the patient that heart is okay, focus on smoking cessation and lung problem?
this one looks like COPD.
Yes.
Yeah.
Right heart
Yes.
problem.
And also, I'm just asking the group that if we do a point of care ultrasound and LV function good, no valve problem, we can assure the patient that and the family that you don't need to go to the bigger city and try with this and stop smoking and continue with the good pulmonary care.
He should quit smoking, because if the patient has got COPD and he continues to smoke, any medicine is not going to work and he will continually deteriorate. The second thing, this patient's heart size, everything is okay. Heart is not that much tubular, because in COPD, it is a low flat diaphragm and the hypertensivency, everything is there. The heart does not look like that much tubular. So if still now this patient quits smoking and starts on pulmonary medicine regularly, he will do good for a long time and will remain asymptomatic. He will be symptomatic, but his symptom will be able to control his symptom by pulmonary medicines.
And সবচেয়ে ইন্টারেস্টিং থিং, আমাদের দেশে কিন্তু সব ওষুধ পাওয়া যায়, গাইডলাইন্স ডিরেক্টেড থেরাপি, even the naproxen inhibitor and sacubitril valsartan
Yes.
combination, it is available. The SGLT inhibitors available. The aldosterone receptor antagonist available. The carvedilol is available, metoprolol succinate is available. So why we cannot treat them in the remote areas if we at least can help? And yes, in many patients, the LV function can get better. If it does not get better, then we can do something. And this is the
Hafiz,
reason why you are discussing.
Hafiz, regarding this patient ECG, though I am very much convinced it is a COPD, as the patient is a smoker, I will do a CT scan, HRCT scan, because if you look at the right costophrenic angle, this is blunted, looks like the left costophrenic angle is very clear, the right one is not like that. So there may be a small effusion, but maybe pleural thickening, but in a smoker, effusion, COPD, HRCT will be reasonable.
So বরেন্দ্র যেটা বললেন যে রোগী যদি অ্যাফোর্ড করতে পারে, প্রাথমিক চিকিৎসা আপনি দিতে পারেন, অ্যাসিওর করতে পারেন যেটা হার্টের প্রবলেম না, ব্লাড প্রেশার কন্ট্রোল করতে পারেন। তারপরে যদি রোগী অ্যাফোর্ড করতে পারে, ঢাকায় এসে সিটি স্ক্যান করে দেখলো যে কোনো নোডিউল আছে কিনা, কোনো অলরেডি কোনো ক্যান্সারের সাইন আছে কিনা, কোনো স্মল প্লুরাল ডিফিউশন আছে কিনা। সো আই
of this effusion,
we don't know, but we'll have to cater according to the patient's financial thing, right? So Rafiq bhai jawar age, I just wanted to show you this. This is a rickshaw puller. We showed this before. It is interesting. He gets dizzy and then he feels fatigue and he feels afraid to work. This is a very poor guy in terms of finances. And several times this happened. আমি মনে করছি যে I will ask them to give adenosine, but adenosine is not available. বাংলাদেশে adenosine দেখলাম পপুলারই বানায়, আর কেউ বানায়
অ্যাভেলেবল তো, হলো অ্যাভেলেবল,
widely available.
ওয়াইডলি আমরা তো ডেইলি ইউজ করি অলমোস্ট।
সো মাহবুব,
Yesterday also.
এটাই তোমাদের সমস্যা। তোমরা ঢাকায় বসে মনে করো অ্যাভেলেবল, বাগেরহাটে we have no knowledge of
না না, সেটাই আপনি ইউ আর টকিং অ্যাবাউট এট দ্য পয়েন্ট অফ কেয়ার, রাইট?
AD card is available. I think popular pharmaceuticals produce this medicine and is available around the country.
না, উনি বলছেন যে রিমোট এলাকায় আনলাইকলি।
We did not have an echo machine in the entire district of Bagherat. When I learned this from Muktabhai, I was sad and I was shocked. My brother-in-law, who had acute MI and probably died, Rafiq bhai mentioned about this 15-20 years ago. There was no defibrillator in the city of Pabna. He died. So it is very personal. So this adenosine business, I learned that it is available in Pabna, but only one person knows that it is available, who is the cardiologist. Nobody else knows that it is available. So the sad part is that, I don't know, Rafiq bhai is still there. I send it to Rafiq bhai and then we send this patient to Dhaka and ablation. And I tell you this, sometimes I feel like so privileged. We had a similar patient 3 days ago in our ER. Patient came in, we gave adenosine, it breaks, then it comes back, it breaks, then it comes back. I called the EP guy. He was my EP doctor, Dr. Namazi. He was in the dentist office. I called him and he said, with the dentist chair, he looked at the EKG. I said, looks like AVNRT. And then he said, send the patient to the cath lab. I'm coming to the dentist office. I left the hospital. By the time he came in, 20 minutes it took him to do the ablation. Patient is done, 20 minutes. Rafiq bhai, why cannot we do this in Bangladesh? This is a 180 million population country. We have only 1 or 2 labs who can do ablation. Is it enough?
Hafiz, if you go to the conferences in Bangladesh, did you ever hear adenosine? Because see, we hear about left main, hyperfunctional stenosis, TTO. Do you hear about valves? No, because those diseases don't exist in Bangladesh. We only have, I'm being sarcastic, but the question is national policy, national health care. Do we promote bypass surgery in Bangladesh? We don't. It is the cheapest modality of coronary artery disease treatment in a third world country. We talk about angioplasty all the time. So these are all national policies, and you cannot get into this debate or discussion. How do you bring up your children? In traditional old Bangladesh, a educated kid from a solvent family used to be a school teacher or college teacher. But we don't anymore. So who is going to be the electrophysiologist? So the country has to promote it. It's a national policy issue. So, and if everything is tied to finances, and everything, how much money you're going to make, then you will not see the development of this kind of fields. So that's something that the country needs to make a decision.
So
Everybody,
Hafiz bhai lost?
everybody talking.
Yeah, Hafiz, I cannot see the screen.
Have you got disconnected or something?
Looks like he got disconnected.
Yes, he's disconnected.
Hafiz,
So Dr. Lay, did you learn some Bengali today?
I learn as much as I can.
But these meetings have been wonderful. I mean, I'm from Bangladesh. Hafiz from Bangladesh. I left Bangladesh in 1982. But the field of cardiology has developed so much. I mean, we can debate about availability of adenosine.
you never left Bangladesh.
That's true. My heart is always there. But development of cardiology in Bangladesh is amazing. It is amazing. I mean, what has happened. I think the question is the availability in other remote areas, and that is tied to finance. Bangladesh used to be the poorest country in the world. It is now 34th or 44th biggest economy in the world, but still we have a long way to go.
Yeah, I think it's very similar to where I grew up in China. I mean, now it's a little bit more advanced, but like remote part of China is still having similar issues. It's great to hear other opinions and.
Hey, Hafiz কে দেখা যাচ্ছে।
yeah, so basically, Rohit bhai, with that knowledge about this rickshaw puller, we had another SVT in a Bagherat camp, and as you know, we actually were able to tackle that, and then brought that patient also, and thanks to Mohsin, we did the ablation, and patient got cured. It was a AV nodal re-entry TAC, very simple. Success rate is what, over 95, 96%, and very rewarding because this is a cure for life, and it is very rewarding. And I think we should have arrhythmia centers, and আমাদের ডাক্তারদের জানতে হবে যে এই রোগী এইগুলা আছে এবং এগুলা হলে ট্রিটমেন্টও আছে এবং যে ট্রিটমেন্ট খুব ডেফিনিটিভ। তো আপনারা যারা বাইরে কাজ করেন তারা এরকম রোগী পেলে এই ইসিজিগুলো আমাদেরকে দেন, আমরা আপনাদের পাশে দাঁড়াই এবং আপনাদেরকে বলি যে কি করতে হবে, এবং টুগেদার আমরা মনে হয় উই ক্যান মেক এ চেঞ্জ। তো 1 ঘন্টার বেশি হলো, তো যদি কারো কমেন্ট থাকে, ইফ ইউ হ্যাভ এনি কমেন্টস, আদারওয়াইজ উই আর গোইং টু কন্টিনিউ সিমিলার প্রোগ্রামস ইন ফিউচার। কারণ আমরা আজকে আলাপ করলাম প্যালপিটেশন এবং চেস্ট পেইন, আর কিছুটা আমরা আলাপ করলাম শর্টনেস অফ ব্রেথ। So we'll go with this theme that 8-9 symptoms, that's how they present, and we can filter them out. That how we can filter them out so that the local patients will have confidence with us. That ওখানে গেলে খারাপ হলে ওরা ধরতে পারে, ভালো হলে ওরা বাড়ি পাঠায় দেয়।
Any comment from Dr. Nilesh?
Yeah, no, I think the efforts in interventional cardiology are seen as the precedent in Bangladesh, but we are right that as a whole we should improve the many other subspecialty. Echocardiography has very well developed. Interventional cardiology is well developed. Non-invasive has ways to go, and similarly electrophysiology. Because I think one thing what we can offer in electrophysiology is possible cure, which is not possible sometimes in other fields of cardiology that we can offer to the patient. So this definitely can be like a life-changing event for the patient, especially for EP problems sometimes.
And Dilish, I will add that with one reminder from our national professor, Professor M.M. Malik. I really admire him. He foresaw this burden of diseases. He started his career in rheumatic heart disease, but then he was able to foresee the spectrum of diseases, particularly the coronary disease burden. And he established big centers and all that. But when Rovik Bhai mentioned about left main and bifurcation and advanced interventional thing in Bangladesh, yes, we are talking about that. Yes, we are talking about STEMI and non-STEMI high risk. We have a lot ahead to do. Arrhythmia we need to do. But what he told me, pushing me aside and saying, why don't you guys talk about preventive cardiology? And don't forget that. How we can prevent this. He was big in smoking cessation or smoking avoidance. And উনি চাচ্ছিলেন যে স্মোক যাতে না হয়। আমাদের প্রফেসর নুর ইসলাম আমরা ধূমপান নিবারণ করি আধুনিক এটাও করছেন। আরেকটা হলো যে হাইপারটেনশন কন্ট্রোল, হাইপারটেনশন ক্লিনিক, hypertension management, cholesterol management, national guidelines on cholesterol. So all these are very important. And diabetes, very, very, very important. The diabetes, the mantra should be hemoglobin A1C less than 7 to prevent any cardiovascular complications. So আমি সবাইকে থ্যাংক ইউ দিচ্ছি যে এই রাতে এত সময় ধরে আপনারা যে কথা বললেন এবং আমাদের যারা রিমোট এরিয়ার ডাক্তাররা জয়েন করছেন তাদের সাথে কথা বললেন। আপনাদের কারো কাছ থেকে কোনো কমেন্ট আছে কিনা বলেন, তমাল বা অন্য কেউ?
আসসালামু আলাইকুম, আমি ডক্টর ফিরোজ বলছিলাম বাগেরহাট থেকে। স্যার
জি
স্যার, ইনিশিয়ালি আমরা ইসিজি অনেক সময় চেঞ্জ পাবো না। তারপর আপনি যেটা বললেন যে 2 ঘন্টা আমরা ওয়েট করাই পেশেন্টকে, দেন আমরা একটা রিপিট ইসিজি করাবো। সাথে একটা ওপেনিং আই তো আগে একবার প্রথমে একটা করেছি, দেন ওটা পিক হইতে তো 12 থেকে 48 ঘন্টা লাগে। সেকেন্ড টাইম যখন আমরা ইসিজিটা করাবো তখন কি আমরা ওপেনিং আই রিপিট করাবো? কারণ ওটার যে ফিনান্সিয়াল যে খরচটা ওইটা তো অনেকে এফেক্ট করতে পারবে না পেশেন্ট।
রিপিট ইকেজির ব্যাপারে আমি জানি না অন্য স্যাররা কি বলবেন। আমার মন্তব্য হচ্ছে যদি পেশেন্টের চেস্ট পেইন না থাকে তাহলে রিপিট ইকেজি করার দরকার নেই। যদি চেস্ট পেইন স্টিল থাকে তাহলে অনগোয়িং চেস্ট পেইনে if you do repeat EKG you may see new change and that may be significant. And troponin, yeah, Boranda.
The last SCC guideline published in February in circulation 2025 SCC guideline on ACS, they have told that if the patient is under observation, so EKG should be next EKG should be guided by 2 things. One, where during observation, if the patient develops chest pain, do an ECG immediately. And another one, if his BP falls and his clinical condition deterioration, you do an ECG at that time. And how many ECGs should be done, they did not mention. But they have told that it should be guided. If the patient develops during observation chest pain, do an ECG. If the patient is asymptomatic, there is no choice that why we should go for another EKG. So if the patient's clinical condition deteriorates, do an ECG. If the patient develops again chest pain, do an ECG to see any new change. So it should be the guideline.
এবং এটা খুবই ইম্পর্টেন্ট যে চেস্ট পেইন না থাকলে আবার রিপিট ইকেজি দরকার নাই। আর সেকেন্ড কথা হলো যে যদি পেশেন্টের অবস্থা ডিটোরিয়েট করে ইন এনি সিচুয়েশন, চেস্ট পেইন ওয়ার্স, ব্লাড প্রেশার ড্রপ করলে আমার অ্যাডভাইস হলো যে ইন দ্য অ্যাবসেন্স অফ নাইট্রোগ্লিসারিন যদি ব্লাড প্রেশার ড্রপ করে immediately think about transferring the patient. You don't, because you are a small center, you don't have all the resources.
Hafiz, the question is a little
True.
different.
Yeah,
When the first concern, would you repeat an EKG or would you do the troponin? That was the issue because
I would do
They have
both.
mentioned both.
Okay.
They have mentioned both.
So let me handle that.
SCC mentioned both.
No.
SCC mentioned both.
Let me handle this way. Rafiq bhai, if the repeat EKG is changing, I don't need to repeat the troponin to save money. Is that your question?
the
But
question would
only
be,
thing, Hafiz,
No,
one
let
thing
me-
I
let-
want to
let me-
mention
no,
regarding
let me
the
finish the question.
ACS patient to roll in, to roll out or observation, the ESC has got a guideline published in 2020. They have told the 1 hour at 1 hour interval, they recommend to roll in, roll out, or to observe the patient.
So Baranda, just to tell you
That
this,
they have got an algorithm.
yes. So আপনি জানেন যে I am now doing the roadmap with the World Heart Federation because ESC mainly focuses on Europe. United States SCC focuses on US. But what about the rest of the world and the resources? So guidelines are guidelines, not Bible. We need to look at our resources and our practicality. The ওই ডাক্তার ফিরোজ ও বাগেরহাট থেকে জিজ্ঞাসা করতেছে আমাদের কাছে যে আমি কি রিপিট ইকেজি করাবো নাকি রিপিট ইকেজি এবং ট্রোপোনিন দুটোই করাবো, কিন্তু রোগীর পয়সা লাগবে তো সুতরাং আমার কথা হলো কি যদি চেস্ট পেইন না থাকে তাহলে রিপিট ইকেজি করার দরকার নেই। আর ট্রোপোনিনটা
is enough.
এক্স্যাক্টলি, যদি রোগীর পয়সা থাকে, রোগী দাপাদাপি করতেছে, পয়সার গরম, ইকেজিও করো ট্রোপোনিনও করো, কিন্তু যদি
না, আমি ফিরোজকে আরেকটা জিনিস বলবো যে অলওয়েজ কনসেন্ট্রেট অন দ্য প্রেজেন্টেশন অফ দ্য পেশেন্ট।
ইয়েস
দেখা
কনসেন্ট্রেট অফ
যাচ্ছে
দ্য
যে
পেশেন্ট,
পেশেন্টের সিমটম এন্ড ক্লিনিক্যাল ব্যাকগ্রাউন্ড, পেশেন্টের বুকে হাত দিলে একটা পয়েন্টে দেখা যাচ্ছে টেন্ডারনেস, ও তো
Only
ব্যথা
thing
যাবে না, ও যাওয়া আসা
we
করবে।
we must
History and
understand that
physical examination will guide you
Exactly.
which patients go further or not.
এবং
because
তুমি
serial ECG is very important because 15% of patients who ultimately develop STEMI, their first ECG is normal. It's non-diagnostic.
রাইট। সো বরেন্দা ভয় দেখায়েন না, we have a backup mechanism. That's why we are confining the patient for 2 to 3 hours and repeat the troponin. কিন্তু আমি আরেকটা কথা বলবো, in the meantime ফিরোজ আপনি ওই ইসিজিটা আমাদের আপলোড করে দেন আমাদের সিস্টেমে, সো ইউ উইল গেট রেসপন্সেস ফ্রম আস, ইউ আর নট অ্যালোন, বুঝছেন, আপনি একলা না, এবং রোগীকে বলতে পারবেন যে ব্যাক এন্ডে আমাদের এক্সপার্টরা আমার সাথে আছে। উই আর ট্রাইং টু টেক ইট অ্যাজ এ কালেকটিভ রোল। ঠিক আছে, তাহলে আমাদের সবাইকে ধন্যবাদ। দিস ওয়াজ ভেরি, আমার কাছে এটা খুব এন্টারটেইনিং। আমি জানি না আপনাদের কাছে কেমন লাগলো, বাট ইট ইজ এ ভেরি ইম্পর্টেন্ট থিং, and maybe we need to come to a national dialogue on this, and maybe we should start a national network where anybody can upload an EKG and then we can jump and then see what is the clinical presentation, যেটা মাহবুব বললো, and then we can advise. রফিক ভাই যেটা বললেন যে আমাদের নাই নেগেটিভ, কিন্তু আছে অনেক কিছু, ইন্টারনেটটা তো ভালো আছে, আমরা তো সবাইকে চিনি, কেন আমরা সবাই কোলাবোরেট করতে পারবো না? ঠিক আছে, কোনো ফাইনাল রিমার্কস?
Thank you, Hafiz. Thanks for
Thank you.
Next meeting.
It's
Thank
very
you. Thank you.
entertaining and
Thank you, Hafiz.
learning from,
I apologize to Jeff and Nilish. We use some our own language, but hang on.
No worries, no
Okay.
worries.
All right,
Help
thank
us
you.
improve our Bengali. Thank you, everyone.
Okay.
Thank you.
Thank you, Dr. Hassan.
Thank you.
And
Thank
it's
you so much.
also important to know how things are happening in resource poor area, right?
Yes.
Exactly.
We are spoiled in US. Yeah. Thanks. Thank you.
Okay. Thank you very much. Okay.
Thank you.
Bye. Okay, bye.
আসসালামু আলাইকুম।
Assalamu alaikum.
স্যার আসসালামু আলাইকুম।